public health services and healthcare services. And what I want to do is showcasing some of the experience in making those essential public health operations operational during the Corona pandemic and now during the refugee crisis in Germany. So this is a case study of the essential public health operations in action from Hamburg. And actually, I should probably say that for many of us who are working in health systems, health services, and public health, the Corona pandemic in some ways reminded us of Charles Dickens' The Tale of Two Cities. It was the best of times and it was the worst of times. It was the worst of times because we lost a lot of lives and it has been extremely tough on people, lockdown policies, and it took a little bit of time until we had vaccines available, and then distributing vaccines and making this an equitable effort throughout the society with ethical frameworks was extremely difficult. And at the same time, it was also the best of times because we learned so much about how to integrate between public health services and healthcare services that this has been a marvelous experience, I would say, at least from the standpoint of the public health services in Hamburg. So what I will do now is just look into where are we a decade after those essential public health operations have been adopted by WHO, and that's a European perspective because WHO has been promoting these 10 essential public health operations since 2012. So they basically promoted this for 10 years. And so what is a bit complicated is that public health is being segregated into individual functions, starting with the classical public health functions around monitoring and surveillance, health protection, and then going into the health promotion, disease prevention, again, where we are coming to the interface between health services and public health services, or health care services and public health services, and then the organizational operations, governance, workforce, organization and finance, communication, and research. And so what I will present to you is the three chunks. So the EPHOs, essential public health operations 1 to 3, in one chunk. Then in the second chunk, health promotion, disease prevention, and communication, and then the organizational operations. I should say that whenever we look at WHO policies, it's very useful to have action plans. It's very, very useful to have strategies. And I think WHO, the World Health Organization, has been very important in adopting these frameworks. And then when we look into real life, which is the right-hand side, we see that the real life sometimes looks very different in terms of public health services on the ground. So what's functioning, what's not functioning. I kind of like this image of the elephant. I think is also across. It's an elephant of a beautiful animal, but it's very big as well. And sometimes it's of course slower than other animals. So the elephant in the room is something where I'm looking at when we looked at what happened when Corona hit public health services. And again, this is an example, a showcase from Hamburg, which is one of the cities in Germany. It's got about 2 million people when Corona hit in early 2019. We had 7 public health offices with strong legal autonomy. These offices were nearly unchallenged for 2 decades. There's also been very few developments in terms of personnel. We were confronted with public health sector or public sector incentives, or if you will also disincentives. So incentives meaning you have a regular 9-to-5 job, maybe in comparison to health care where you have on-call duties. So that's an incentive for people to work, but it's at the same time, it is an incentive to go a little bit outside the scope. And that's what we had to do when Corona hit, starting in 2019. A lack of a digital agenda, definitely, a lack of central stewardship. So the ministry was not at the time in 2019, not so strong in Hamburg to really govern the public health services. And as an effect of that, public health services were fairly fragmented with poor integration. And also we probably had too few research initiatives and not a very strong research orientation. So we're coming to the operations 1 to 3, which is surveillance, monitoring, and health protection. And I have to say that this worked pretty well right from the beginning. So our epidemiological services were quite good. They started to monitor from a sort of line list reporting. We very quickly went into systematic, first of all, Excel, but in a digital, very quickly a digital collection and presentation of data. And then also we looked at how SARS-CoV-2 cases cumulatively in Hamburg developed over a longer period of time. And we also were able then in time to link the lockdown measures to the development of cases. And that was also true for cases, fatality cases, mortality, and also cases, for instance, in hospitals. So I think the monitoring worked really well, and linked to that also the health protection. Our public health services in our harbor, we have a big river harbor and a big medical office and public health office taking care of that harbor worked really, really very effectively. So surveillance, monitoring, health protection worked. I think surveillance has been incredibly increased. This is Omicron. This is a global scale in 2001, and you see it sort of reports November to December. This is the development of cases worldwide at the time in November, December 21. And linked to that, we established then the surveillance of corona variants in Hamburg very early. That was a good also research cooperation, public health and research, because we contracted the University Clinic of Hamburg to perform a systematic surveillance of variants of concerns. So they used a sample of by chance selected sample of probes, of PCR probes, and then by this they could, by performing molecular analysis, they could be prospecting the development of variants of concern like Delta and Omicron later on. Coming to health promotion, disease prevention, communication, essential public health operations 4, 5, and 7. So obviously, when corona vaccines became available in early 21, or actually very late 2020, we started in the public health service to excessively promote corona vaccination. We had corona vaccination days. We went to schools. We provided counseling and advice to school classes, and that was done in the public health services in Hamburg. And we beefed up and scaled up our mobile information services. And this was a combination of a health promotion prevention and communication effort. So we also had teams with vaccines going into schools later on and offering vaccination to make it more practical. So a colleague is coming in here. I'm in Stockholm. I think where we really have some innovation and that's 2022 now, is the cooperation with mobile vaccination services and counseling services, because and that's not so much due to corona only, but due to the refugee. Well, I would say it's a refugee crisis in 2022, because Germany received, additionally to the somewhat 160,000 people that are coming every year as asylum seekers or refugees, Germany received about 1 million people escaping from the war in the Ukraine only in 2022. So we needed to really do something about scaling up our vaccination, counseling, health promotion services, screening services, for instance, for tuberculosis, HIV, AIDS, hepatitis B and C. And that's where I'm presenting to you now an integrated public health services and healthcare initiative, where we have a sponsor from the German railway, the Deutsche Bahn, and the corporation Cisco, which provided us this beautiful bus you are a star, you are safe, and there's a QR code, and this mobile bus has a schedule, and people that arrive in Germany and scan the QR code can see where the Medibus is. And what is exceptional about the Medibus is that it provides an examination room, a waiting room, and it provides an integrated video translation system. Basically, they have two screens, and click, you just mouse click and have available 50 different languages. So Cisco is working with 750 interpreters worldwide, globally, and so they are available on a 12 hours or 15 hours a day basis. And the only thing that we had to do in Hamburg from the public health services, we were governing this activity. It's a sponsorship. So it is free of charge to the city of Hamburg, and Berlin and Cologne have introduced this as well. And so the Medibus is provided, the video translation system is provided. It even has refrigerators to have vaccines in the bus, which are also monitored in terms of temperature. And the only thing we had to provide, we didn't even have to provide the bus driver, was the healthcare professionals. And it made it very attractive also for healthcare professionals because they really loved working, or they love working in this bus because it's going to the people in need. So the bus is moving around the city and is actually trying to fill gaps because we've received such a high number of additional guests in Hamburg in 2022 that our routine services, especially because of the translation and language interpretation issues, that we needed to set up some parallel services. So this is a public-private partnership between the public health services, healthcare, but also two private corporations, which is the Deutsche Bahn and Cisco, with the Medibus. Important here is that health authorities are literally in the driving seat of coordinating these services. We just get the bus and the bus driver and the video translation technology. And the Medibus helps fleet operation. It's got four buses, and the whole of Germany has treated more than 10,000 patients, but also provided more and more counseling on top of those services. Let's look at public health staffing. So we're coming to the governance, so EPHO 7, 8, which are governance, workforce, and organization. In the corona pandemic, the German federal government decided to upgrade public health services. So what you see here are numbers in the public health offices. We started pre-pandemic with 390 full-time equivalent staff in the city of Hamburg, catering for about 2 million, so 1.8 million inhabitants in the city of Hamburg in 2019. And during the pandemic, we recruited additionally 910 people. And what's beautiful is that the German government then adopted the Public Health Strengthening Act, or Pact, which provides 4 billion euros into public health services, by which we can now recruit on a long-term basis 110 additional full-time equivalent staff until 2026. So this means it's a substantial commitment to strengthen public health services at national scale. There's also a component on modernizing IT systems and making public health services more attractive. And coming back to this initial image, this was why we also consider the pandemic as being a chance and an opportunity to strengthen public health services, as painful this experience has been. And the EPHO number 10, which is research, this has been maybe one of the strongest improvements in terms of public health operations, because we substantially gained momentum with cooperating between public health services and research. I already gave you the example of surveillance earlier on, where public health services were advised more and more by laboratories on outbreak, for instance, but also on variants of concern. And this sort of cooperation improved also surveillance, which also has a research element with it, although it's also part of the essential public health operations. What we did in Hamburg in 2020 was a research cooperation with the how do you call them, the funeral, not the funeral, I don't even know how you call it in English. So it's after post-mortem, examination post-mortem. And the university clinic performed post-mortem evaluations of 600 COVID-19 associated death in 2020. And this then meant it was a part was just examining the administration records, then CT scan in a minimal invasive form, and autopsies. And this generated a lot of insights in 2020 about the causes of death in COVID-19 mortality. And it was a very important research cooperation between public health and the university clinic performing those autopsies in 2020. We still look at the internal challenges we had. So even now we look back and we need to admit that public health services in Hamburg were not sufficiently prepared for this dimension of the pandemic at the very start of it. And then some of the potential for health promotion and disease prevention was realized too late. We did probably well on corona promotion and disease prevention, but we didn't use the opportunity to make the point that it's actually chronic conditions that forms the basis for COVID-19 death, and therefore there's a real momentum for promoting health promotion and disease prevention, even on the basis of the corona pandemic. And I think this potential we utilized too late, and we realized too late the collateral effects that lockdowns had. Communication was to some extent working and functional, but it was very complicated due to many players. So we have the federal government communicating and forming the national framework, and we have 16 federal states, which also are responsible for providing services, and that made it very complicated and to some extent also fragmented. And we had a preparedness plan for an influenza pandemic. So it was a respiratory disease that it was prepared for based on a global, regional, national framework. And Hamburg also had a Hamburg framework, a preparedness plan. But we have to say that responsibilities and roles set out in this plan were not ideal and fit for purpose. So we have to revisit this plan again now. The opportunities we took, we even further strengthened surveillance and monitoring in the course of the pandemic. We more and more developed and used digital tools. Mind you, at the beginning I said we didn't have a very big digital agenda when we started. We definitely substantially strengthened workforce throughout the country and have now to walk the talk to also make sure that we retain qualified public health staff in the system. And we certainly improved coordination between all levels: political, policy, public health services, research. So coordination and communication between those actors improved substantially. We developed on common goals and objectives between healthcare and public health services. We worked very much hand in hand with healthcare providers, hospital providers, intensive care unit, people that provided us with advice on difficult directions, because it was the hospital beds, the hospital capacity that we started to be worried about after we had vaccines available, and when the numbers went up, so rocket up. And we created effective partnerships with service providers and research. So overall, I think we did a lot, and of course we need to move ahead. We need to further improve integrated molecular surveillance. So not only looking at COVID-19 now, but also other infectious diseases. Strengthening for the next time around to be better prepared next time around. We need to further or earlier look at the side effects of lockdown measures, for instance, psychosocial effects on children, strengthening screening, improving services integration between public health and healthcare. So it's only the beginning. We need to continue push on that. Strengthening governance of public health authorities. I mentioned already retaining qualified public health staff as we now implement the Public Health Strengthening Act. Obviously, walking the talk and implementing this act well, also with the digitalization agenda. We need to go back to communication and critically assess communication, both at the technical as well as at the press and public communication level. We certainly need to build on being more proactive in governing good research from the public health services point of view. So thank you so much for your digital attention. It's both good and bad, but lots of opportunities to go on. So togetherness helps, and let's go. Thank you.
Thank you so much for such an initiative. Keep it up. Any questions for her? You can raise them in the chat. We'll move on to the next presenter.